MS falls under autoimmune disorders. We don't know the exact cause. The problem here is there is demyelination of the myelin sheath. So the nerves on the body, which transmits on the muscles, which transmits impulses, making muscle movements possible, are demyelinated. Not all stretches, though, are demyelinated. Only patches of it. Meaning there can be long stretches of nerve fibers who are intact, but there will be patchy areas of demyelination. So in those patchy areas that don't have the myelin sheath, this will cause incomplete muscle movements, meaning the patient here will have problems with coordination. There is, as I mentioned earlier, there will be tremors here, but the tremors are intention tremors. Okay. There's no problem with dopamine, no problem with acetylcholine here. The problem is the demyelination. Now, what causes the demyelination? That's what we don't know. It's destroyed by our own autoantibodies. So this is, again, falling under an autoimmune disorder. So as with any other autoimmune disorder, what is the mainstay of treatment? Because you have antibodies that attack and destroy the myelin. So what is the mainstay of treatment? It's an autoimmune disorder. So just like RA, lupus. So what's the treatment? Immunosuppression. MS can occur at any age. The peak, though, is between 20 and 50. So you guys are not out of the woods yet. More women than men. So here's the picture. This is your normal nerve fiber. And this is what happens with MS. So auto-destruction of your myelin sheath. As already mentioned, no known cause. We don't know. As like with any other autoimmune disorder. So management will be immunosuppression. Management. Manifestations first. So the patient's main complaint here is fatigue. There will be pain, but the patient's main complaint is they're tired all the time. They of course have the tremors in addition, but how old is this patient again? Between 20 and 50. Okay, so pretty active childbearing age women. Of course, there are men, but honestly, I've never seen an MS. Well, I did see a few male MS patients, but most of them are female. There are different types, but the most common type is the remitting and RRMS, meaning remitting relapsing type of MS, which is 85% of most cases. So we'll focus on that. I will disregard the other 15. The patient's early manifestations starts with the eyes. There are eye and vision problems here. Number one complaint is diplopia or double vision. Then they complain of blurring vision, for instance. And then, as already mentioned, fatigue is the main complaint. They're tired. So what happens with their job, school, relationships? Okay, tired. Okay, so it's debilitating. These factors contribute more to the fatigue. Then, especially with these heat waves we're having, so this is not good for MS patients. As already mentioned also, pain is another complaint. So we have fatigue, eye problems, and pain. So you think you can hold the job? Very difficult. Muscle pain. Demyelination. These are the options for pain management, but among all of these, the most effective really are the antidepressant and anticonvulsant medications. Opioids have more side effects rather than benefits for MS patients. So we We will see them more taking antidepressants and anticonvulsants like gabapentin, for instance. Another main complaint is muscle spasticity. So spasms of the muscles, okay, hard to move, very uncomfortable. They not in the back only, but also on the arms and legs. So what happens to relationships when you have these manifestations? Like, are you in the mood for intimacy? Okay, no, not with all these symptoms. And with, I don't know if it's the nature of the disease, but could also be a psychological effect, well, because you're young and you have these symptoms. So patients will have the emotional lability, which will again cause disruptions or conflicts in intimate relationships. And plus, there's bowel, bladder, and sexual dysfunctions. Although there is no problem with fertility, however, with immunosuppression, it may be affected because no, immunosuppression will, of course, affect not only the bone marrow, but any other rapidly dividing cells, right? Including ova and sperm. UTIs is a common problem, constipation, pressure injury, because again, these patients usually are either chair bound or bed bound. Because they have bowel and bladder problems, meaning they become incontinent. And incontinence, and plus you're tired. I mean, do you get up and wash every time? Probably not. Okay, you just sit on your diaper. Okay, so this is a chronic disorder, so they stay home, right? But there will be flare-ups. The number one trigger for flare-up is stress. Is stress the same for everybody? Can be anything. So let's say you have MS, you're in school, so your stressor will be, okay, Mr. Scarda and exams, okay? So that will be your stressor. Because these patients have an autoimmune disorder, so to put you into remission, meaning symptom-free, you'll be on immunosuppressants, right? But when you have flare-ups, meaning your symptoms are multiplied so many times, meaning the pain, the fatigue, the spasms are double or triple their usual severity, they'll be hospitalized and placed on high-dose steroids. Unlike everyone else who have shorter lifespan, MS actually patients live relatively normal lives. We see them in nursing homes, so that means they're getting older, yeah? So you still have MS patients in nursing homes, although again, the quality of life is another story. Yeah, they live long, however, not the best kind of life. I mean, look at the symptoms: fatigue, pain, spasms, okay, the eye changes, plus complications of immunosuppression. So if they're on immunosuppressants, what likely will be their lives while in a nursing home? They'll get what? Infection. So you'll see frequent hospitalizations related to that as well. So just like ALS, Huntington's, what else did we do today? Parkinson's, no cure. Okay, so MS, no cure. Yes, symptom management and immunosuppression to keep you in remission again. That's the main goal. Put you in remission as long as possible. It's not really effective. It's not really known to be, unlike Guillain-Barré syndrome, wherein yeah, it's effective. Not so for MS. So here are our treatments. So just like RA, because RA was also a autoimmune disorder. So we've got disease modifying therapies, interferons. These are expensive. These are subcutaneous injections. They come in like Lovenox. You've seen Lovenox injections? Yeah, just like that. So same package, almost like identical looking. So same pre-filled, same mechanism. They also have a spring. Okay. I remember though, these are refrigerated. I know. Put them in the fridge. They daily subcutaneous injections or every other day, depending on the order dose. But these are expensive. Interferons, immunosuppressive or immunomodulators are very expensive medications. As with any other immunosuppressants, what are the side effects? Bone marrow infection. Bone marrow suppression. So which is leukopenia, and then we will have anemia also, and thrombocytopenia. Okay, same. There is a PO. Oh, no, sorry. PO is fingolimod. Okay, so glatiramer is another daily injection. I think this is Copaxone, if I'm not mistaken. Fingolimod is PO. So at least they're not all options are subcutaneous injection. So there is a PO option, fingolimod. And as already mentioned, when these people have acute exacerbations where they have really severe symptoms, they'll be hospitalized and placed on IV steroids. We use methylprednisolone. Here's a IV infusion option, metocentrone, but exclusively used for exacerbations, meaning this will be what you'll see in hospitalized MS patients will be steroids. The rest of the treatment are all management. So what do you think will be given for the pain, the fatigue, the spasms? So muscle relaxants, right? Can we give antispasmodics as well? Okay. And they'll be given benzos. That's pretty much all we can do with with spasms. Okay, put them, semi-sedate the patient, relax them. What side effect of baclofen? Ulcer. So this is like a NSAID, but it's not an NSAID, but that's usually a problem with baclofen is because it's an acid agonist, so it causes hyperacidity, therefore leads to GI ulcers. Then the rest are for spasms. The propranolol here, it's not like the patient has any blood pressure problem. This is actually for these tremors. Remember, they have what type of tremor again? Resting or intention? Intention tremors. So the propranolol here is for the tremors. And they'll be given bladder medications, overactive bladder medications to control incontinence. And as already mentioned, so UTIs always accompany incontinence. Yeah. That's it.